Hello, my name's Christina Rutten, and I'm going to talk to you about hyperthyroidism. Definition and etiology. Hyperthyroidism is a clinical syndrome caused by excessive circulating thyroid hormones. The pathophysiology. According to the National Library of Medicine, the pathophysiology depends on the particular variant of hyperthyroidism. It results from an excessive synthesis and secretion of exogenous thyroid hormones by the thyroid. Risk factors for hyperthyroidism. Graves' disease is the most common cause. Thyroiditis, toxic adenoma, toxic nodular goiter, a less common form of hyperthyroidism, is caused by overproduction of thyroid hormone due to the presence of thyroid nodules. Exogenous hyperthyroidism is caused by excessive dosages of thyroid hormone. Clinical manifestations. The patient may appear anxious, seem restless and irritable, and have fine tremors. The patient also may be tachycardic and complain of palpitations. The patient may also complain of heat intolerance, along with increased perspiration. You may also see increase in appetite, diarrhea, weight loss, and thin skin. Nursing interventions. You want to minimize patients' energy expenditure, provide a calm environment, assess mental status, monitor nutritional status, monitor intake and output along with their weight. You may need to reduce room temperature, provide a cool shower if needed for comfort. Report a temperature increase of 1 degree or higher to the provider immediately, and monitor ECG for dysrhythmias. Diagnostics and testing of disease. Free T4 index, T4 total, T3 will be elevated in the presence of disease. Blood TSH level will be decreased in the presence of Graves' disease, but it may be elevated in secondary and tertiary hyperthyroidism. Now, an ultrasound is used to produce images of the thyroid gland and surrounding tissue. Electrocardiogram is used to evaluate the effects of excessive thyroid hormone on the heart. A thyroid scan will have an elevated uptake, and that means it's indicative of hyperthyroidism. Medical treatment. Now, radioactive iodine therapy and antithyroid medications are available. The most common used antithyroid medications are methimazole and propylithiazole. These medications block extrathyroidal conversion of T4 to T3. Now, you'll want to monitor for manifestations of hypothyroidism, such as intolerance to cold, edema, bradycardia, increase in weight, and depression. You're going to monitor the CBC for leukopenia or thrombocytopenia. Monitor for indications of hepatotoxicity. And you'll want to tell these patients and educate them while they're on it, they should take it with meals in divided doses at regular intervals in order to maintain an even therapeutic level of medication. If the patient develops a fever or sore throat, jaundice, or bruising, have them report that information to the provider as well. Now, if the patient becomes pregnant, methimazole should be stopped under the guidance of the provider. Radioactive iodine therapy. Now, this is taken up by the thyroid and destroys some of the hormone-producing cells. One dose may be sufficient, but a second or third dose may be needed. It is contraindicated in clients who are pregnant. Advise the patient that the effects might not be evident for 6 to 8 weeks, and continue to take antithyroid medication as directed by their doctor. Stay at least 1 meter away from pregnant individuals, infants, or small children for the first week following treatment. And you'll want to limit contact to no more than 1 hour daily. Use precautions to prevent radiation exposure to others, which can include the following. Don't use the same toilet as others for at least 2 weeks. Sit down to urinate to prevent the splashing of the urine on the toilet. Flush the toilet around 3 times after using the restroom. Take a laxative for 2 to 3 days after treatment to help rid the body of the stool that's contaminated with that radiation. Wear washable clothing and wash them separate from others. Avoid contamination from saliva. Do not share a toothbrush. Use paper plates and plastic utensils when eating. Now, another form is a surgical. It's called a thyroidectomy. And if radiation therapy is contraindicated or if medication therapy has failed, then this is another alternative. Subtotal thyroidectomy and a total thyroidectomy may be a solution. Let's see. Interprofessional care. An endocrinologist, a radiologist, a pharmacist, and dietitian can collaborate in providing care for that client. The more hands on deck that you have is, it's better overall. Complications of the disease. You can have hemorrhage, and this is after a thyroidectomy of some sort. Inspect the surgical incision and dressing for drainage or bleeding. Monitor the surgical drain. Now, there should be a moderate amount of drainage. A thyroid storm / crisis. Maintain a patent airway. Provide continuous cardiac monitoring for dysrhythmias. Administer acetaminophen to decrease temperature. Provide cool sponge baths or apply ice packs to decrease fever. If fever continues, obtain a prescription for a cooling blanket for hyperthermia. Administer thionamides to prevent further synthesis and release of thyroid hormones. Administer sodium iodide as prescribed. 1 hour after administering thionamide medication, administer beta-adrenergic blocking agents such as propranolol to block sympathetic nervous system effects. Administer glucocorticoids if adrenal insufficiency is suspected or to treat shock. Administer IV fluids to provide adequate hydration and prevent vascular collapse. Fluid volume deficit can occur due to increased fluid excretion by the kidneys or excessive diaphoresis. Monitor the intake and output hourly to prevent fluid overload or inadequate replacement. And you're going to want to administer O2 to meet the oxygen demands. Now, airway obstruction, you're going to want to keep a tracheostomy tray and suction equipment in the room at all times. Maintain that bed in high Fowler's position to decrease edema and swelling of the neck. Now, alert the rapid response team if respiratory manifestations occur, and provide humidified air and medicate as prescribed to reduce swelling. Hypocalcemia and tetany. Monitor for indications of hypocalcemia. Have an IV calcium gluconate available and maintain seizure precautions. Nerve damage may cause vocal cord paralysis and vocal disturbances. Monitor the patient ability to speak every 2 hours. Assess their voice tone and quality in comparison to before the operation. And document any adverse findings and report those to the provider immediately. Patient education. You should educate the patient on when and how to take the prescribed medication and how that role of the medication plays on their treatment. And unfortunately, this disease will require long-term therapy. Now, spirit of inquiry. It is through spirit of inquiry and evidence-based practice that we know how to treat and care for those diagnosed with hyperthyroidism. And here is a list of my references.